us identify these things. So I know we've talked about these a little bit. All things that we've talked about today. Look at those, the high confidence of risk factors for chronicity in whiplash injuries. High pain intensity, high neck-related disability, elevated post-traumatic stress symptoms, catastrophizing, cold hypersensitivity, and mechanical hypersensitivity. We've already learned pretty well how to assess all of those if we really want to. Equally interesting, I will say, are those things that we're pretty confident do not affect the likelihood of recovery. And if you take a look at them, a lot of them have to do with the actual collision itself. Impact direction, seating position, awareness of collision, headrest in place, vehicle speed, and then we've got angular deformity and older age. This was the result of a review of systematic reviews or a meta-analysis. The interesting thing about this, and this is the kind of thing that keeps me going as a researcher. I can have two people sitting in the same car out here at the corner of Western and Sarnia Roads, and they can get plowed into from behind. And those two people, despite being in the exact same accident, could take two very different post-injury trajectories. And if I can't blame the mechanisms of the accident, the question becomes, what can I blame? And that's something that we continue to work on here. We're trying to look at perhaps individual factors that might explain this. And certainly Josh and I are going everywhere from genetics all the way up to sort of social support and everything in between to see if we can figure out, and I don't mean just Josh and I, there's lots of people in the world who are working in this area, try and figure this out. I've also got evidence for the low back pain population. So this was a systematic review in 2010. Take a look at the strong evidence of risk factors. Now, things that we haven't talked too much about, actually some of them we haven't talked at all about, non-organic signs, which are Waddell's signs, maladaptive coping behaviors, high self-reported functional impairment. So that's the Roland-Morris questionnaire is the neck-related version of for the low back. Presence of psychiatric comorbidities, and low general health status. So we can hit on some of those. Moderate or inconsistent evidence of non-supportive work environment, high baseline pain, and presence of radiculopathy, shooting pains, and that kind of thing. And then no evidence of risk, history of prior low back pain. That's interesting. So they're actually, in this case, their prior history really didn't have an effect on whether or not they were going to recover. And things like age and sex, which is interesting. It's actually different for neck, so whiplash injuries versus low back injuries. Now, the reason I've given you these things is that if you have a patient come into your clinic and you want to do this assessment and you want to provide a report to some third party, then you can actually take a look at these papers, you can cite these things, and you can say, based on the best available evidence, this person scores high here, here, and here, therefore, they're at an increased risk of developing chronic problems. Now, how much of an increased risk at this stage, I can't really say, but we know it's an increased risk. And that, again, we come back to this term, that triangulation, sort of bringing it all together and saying, these things are all consistent and they are all showing this as being a high risk, that may be enough to get somebody into sort of multimodal care early on. If you can really be confident in your assessment, if you can really put some objective, sort of research-based or evidence-based recommendations forward, say, I believe this person is at increased risk of chronic problems as a result of these things. And so far today, we've learned how to assess certainly all of those. So, I do think that the prognosis-based assessment is valuable from that perspective. The other thing you can do here is with most of these and these, arguably, they might start directing you towards treatment. And what's great now is that I can look at these risk factors and I can come up with a risk-based treatment plan that focuses on modifiable risk rather than trying to spend my time identifying perhaps some tissue at fault or some lesion or something like that. Not to say that there isn't one, but clinically we may not be able to identify it. And I know I've seen too many clinicians who have just sort of spun their wheels for weeks on end looking for that specific joint that doesn't glide in this direction or whatever, where they probably would have gotten a lot better results had they just looked more from a risk-based perspective, said, I'm going to focus on those things that I can modify, and hopefully that is going to prevent the development of long-term problems. So I certainly am an advocate of a risk-based approach to assessment and treatment. hopefully that makes sense. So I think prognosis-based assessment may offer treatment options when traditional tissue-based assessment isn't showing anything. Communicating risk must be performed carefully to prevent self-fulfilling prophecy. I will say again, it does you no good at all to say this person or you are at risk of developing chronic problems if you have nothing to do about it. In that case, I'd rather you just said nothing. Okay? Otherwise, you may cause chronic problems. When risk is low, let the person recover naturally. Minimal intervention, occasional follow-up, make sure things are coming along the way you'd expect them to. When risk is high, I think you've got an argument, and I really do think that the evidence is getting to the point where you can support this argument with scientific evidence that multimodal care may reduce the risk, although the actual evidence, while we can identify risk factors, the actual evidence that we're going to improve outcomes, I have to admit, is currently weak. So the argument would be, based on my assessment findings, this person appears to be at risk of developing a chronic problem unless we address this, and this early on. Leave it at that. I think we can change these with good, sound, individual treatment. And as you've heard me say a couple times today, in general, the strongest predictor of a poor outcome is a high score on the same measure at baseline. Anything about prognosis or risk-based assessment? Does that make any sense? Rather than just sort of looking at tissue-based assessment? I'd admit, in my mind, it's a bit easier. In fact, there's more like science to go on. So I like